there. So without losing much time, Dr. Desai, I'll quickly come to you as a, I'm sure in your domain, wherever you have been doing hospitals back to back across the country and outside, I'm sure there were some projects which were under execution prior to the pandemic, and they were getting into a stage wherein the pandemic happened and we had to change the course. Can you let us know that whether there were any alterations that you had to do to adjust to the pandemic in terms of the design, or any operational thing in terms of patient safety or sterile zones and stuff like that? Were there any course corrections and during this time?
Right. Thanks, Rajesh, and thanks to ET, for conducting this. So yes, we had projects where we were designing. We were almost on the verge of getting approvals for tender, and we had to course correct. You're right, because most hospitals, as I come from city of Mumbai, where hospitals were a little old in their age, if I can say so, and many of them had to shut down, because of not being able to cope up with the pandemic requirements of negative air pressures and vertical transport systems not getting into place. Air conditioning cannot be changed overnight, so there were a lot of problems. And interestingly, we were designing a school of medical research and technology for IIT Kanpur in Kanpur.
Okay.
Plans were frozen, and we were about to tender. And when Dr. Devesh Shetty was on the board, Dr. Maman Chandy was on the board, and we suddenly everyone realized that if something like this happens in future, how do you tackle this? So from a building which was completely designed, we had to change. And what we decided was to go with a 18-meter grid, so that becomes a very narrow kind of a thing, go into a fishbone kind of a design. So I had a central spine of vertical circulation, so I had two vertical circulations. In terms of pandemics, I could use, one of them for that, and then, use the other for the regular kind of a traffic. And to my surprise, it quite worked out well, because 18-meter grid, also allows you a cross ventilation possibility. The room is completely lit, it's not like a flat mass of building. So like that, we had in a project which was yet to begin. And in projects which we are already under construction, we had to course correct to do and imbibe technologies with people like, Schneider and others in air conditioning field in particular, to course correct to see, how to zone out the air conditioning system, and create pockets where we can very quickly change the system, to do a negative air pressure.
Okay.
So that kind of a thing was even vertical elements, in some places we had to cordon off, so those kind of things definitely came in, so there were things like that which had to be done. Apart from that, there were, technologies which came into force, which were like, in one hospital we tried it, didn't work out too well, was robotics to use, to deliver the hospitality factor,
Okay.
So
Okay.
use like what the Chinese were trying to do in terms of the lunches and all,
Yeah.
going to a robo. So, but in IIT project, we probably are going to use that. There is some experience we have had in the Middle East from our office in Dubai, where they can actually deliver workloads from materials management, laundry systems, kitchen systems, all of that. In one case, we were able to also, put in those laundry chutes, even a garbage chute kind of a thing, got tried out. Pneumatic chute, of course, has become now a common practice. So
Right.
technology came to the forefront, no touch or a less touch kind of a thing. That has now become a norm. So doors were overnight changed, foot operated from
Yeah.
operated, taps and other things in many places, especially in a couple of hospitals. We used the taps in intensive care units and those areas where nosocomial infections are a problem, to a copper.
Copper.
Kind of
Yeah.
thing, with the handle. So those were some quick fixes, that we sort of did.
Okay. So, Doctor, before I jump to Dr. Jain for this, one question is that I had seen about a decade ago, when there were some hospitals in Singapore, like you had Kutek Park or those hospitals there, they especially had zones for pandemic. I don't know whether they had this in future, but I did see areas wherein they had large spaces earmarked that if there was a pandemic to come in, there was areas where they would have that water curtain and some sort of curtains wherein the ambulance will be washed before it goes in and stuff. And they had precedented all these things and they did plan for, but these are only possible to large scale hospitals which are like upwards like 1 million or 2 million square foot. Now, in India going forward, for your hospitals, larger hospitals, do you foresee some kind of areas like this earmark? Because I'm sure pandemic will last for another year or so as it slowly trials down. But we need to prepare in future to be
Right.
prepared in
So,
the future. So do you?
correct, correct. No,
Do
so
you
here also, some hospitals were able to very quickly convert areas like dining halls. We took three parking floors in a hospital building near Thane, to convert it into beds. So one thing that we have realized is that when you are going to do your medical gas pipelines and things like that, you would need to probably, now it's of course mandatory to also use PSAs, for larger
Hmm.
hospitals is mandatory that not only liquid oxygen, but you also need a PSA. In
Yeah,
such a
yeah.
case, it is mandatory. Even the National Medical Commission for medical colleges have made it mandatory. So
Hmm.
that kind of a thing has started, where people have realized that, if you have to very quickly change it into something, we will. So our buildings are more tighter than what the Western countries have. So we don't have the luxury of leaving it like that, because you need every rupee to be paid back in terms
Correct.
of yeah. So there, for parking spaces, dining halls, those kind of things, any lecture halls that we create. So even terraces, where you could put a temporary shed. So we've tried all of that, and it works. What we have
Oh,
seen is it does work. Yeah, it can be very quickly done. May not be as engineeringly intensive as they might have done in Singapore, that water
hmm.
curtain and all,
Right,
but
right, right.
water curtains we have tried.
Okay, okay, yeah. Okay, thank you, Dr. Saab. Dr. Jain, Dr. Desai, one quick question to you. Uh, Today, more and more healthcare enterprises are going into single specialty. One of us we are doing one of them, like we are into single specialty. Of course, we did face our own challenges when this whole pandemic came in. How do you see, of course, in multi-specialty, as you said, you have flexibility of assigning spaces for pandemic. You have more and more space available. But single specialties don't shoot more than 30, 40, 50,000 square feet of space. In this case, do you think any change in the design we should look at while tackling this pandemic in future, or any course correction required in single specialty chains?
So I think most of this single specialty comes with a not like an owned asset. It's more on a leased. It's a
Yeah.
leased asset. So it's a asset light in that sense.
All
So I
right.
think in those kind of hospitals, what I perceive is that there will be more importance given to pre-engineered structures. These drywall systems and other things, which are very quickly removable, adjustable. So that kind of a thing probably will come, because when it comes down to push comes to shove, everyone has to contribute. And like Rajiv ji said, the government has also taken upon itself. I could see Indian Railways doing a fantastic thing. Indian Army coming up with modular hospitals in a very short span of time. So those single specialty hospitals, if they have to chip in, and I could see some of them do that, where they converted the hospital into COVID, but then you have to convert the whole thing,
Correct.
so you might lose out on the revenue.
Revenue.
So India's problem is, the technology piece. What Bhupesh was saying, is diametrically opposite with the private sector. I'm saying is diametrically opposite to the public sector. We don't have the infrastructure which matches. So we will need two sets of solutions. One will be for this private player, where we operate, and most of our clients generally are from that side. But we equally important is the public sector, and which is what actually doled us out, because
Yeah.
district hospitals and all are present in the tier 2, tier 3, the Bharat part of it.
Yeah.
We
Yeah.
are mostly in the India part of
Yeah.
it. So we need to strengthen that, and that will call for a very different kind of strategy. Like sir said, in terms of COVID, I am quite proud of that app, because my colleague was in Canada, someone in America. They don't have this kind of an advanced IT digital backbone. They were
Oh,
not able to do it. We did it.
absolutely.
So,
And rolling out such a huge number within this time frame is mammoth task.
yes. And the other advantage which I see, what Rajiv ji mentioned about the digital, now we've allocated 200 crores to the Ayushman Bharat digital mission. I think, what we lack in terms of human resource, say I put up a CT scan MRI in a tier 3 town, I may not get radiologist because I'm yet, creating those numbers. I'm sure in 10 years time we will reach there. I will need that technology to come to you, in a Bangalore or a Bombay where I can report.
Yeah.
So that is going to be important. This was classic because this needed a HRCT, to be installed, but I didn't have people
You
to
didn't.
report on it. So I think those kind of gaps we will be able to fix through this digital
Right.
mission on which the government has embarked.
Yeah. Okay. I see.
And left. So, like I said previously, we are a country which has a public health which doesn't compare with the private. To the government's credit, they are thinking at a structural level change. And they have been quietly chipping away at it. So, if you see from 2014 when this government came and today, we have almost doubled. The number of seats in because we need skill, right? It's easy to push infrastructure, but I don't have number of doctors.
Yes.
I have 0.68 doctors per thousand. I need at least one per thousand. So I need to ramp that up. And this is only the MBBS piece. If you go to the PG, the postgraduate, which is MD/MS, the number falls further. And if I then go to the post PG, which is this DM/MCH, the number goes down even further. Government realized this bang on, and they have been doing their bit of it, creating these aims like sir said, 20 to 25 aims. This thing that we did with IIT Kanpur, and then we did another business plan for IISc in Bangalore, where the idea is in IIT it will be a combination of research between medicine and engineering on the campus, because we need technology today. We buy 80% is important actually.
Correct.
In medical technology, so that kind of thing needs to be structurally corrected because otherwise the cost of projects keep going up. So IIT was one example there, and IISc was another interesting example, which was I think pushed by the PMO. Was that I create an institution. So the IISc project is like a PG institute which will be mandatory for you to do a PhD. Only then can you get admission for the PG. That's for the first time ever. The thinking is that I need scientist doctors and not only the practicing doctor. Only
Correct.
then I will do a genuine Indian research. If I need to give fillip to that Make in India kind of a thing that we want. So that's a very good, thing. Now there is IIT Kharagpur doing it. I'm sure there'll be others also will follow suit. So that's structural level change. The other change which the government is doing is, we are used to electronic medical records, which we take for. So you are say in Fortis Hospital, you get a Fortis medical record. You shift to Apollo, you get a Apollo medical record. Both don't talk to each other. You will need to carry one Apollo, one Fortis. The move is to make an electronic health record which is seamless. So that will actually allow you, it's like COVID, you can access it anywhere in the world, right? So this will allow you to access your health record anywhere, and this will create a change. In this, what they're doing is they are going to make a registry of every single doctor, clinic, nursing home, hospital, whether government, private, doesn't matter. So that's another major structural change. I'm hopeful that it happens within a year or two. Dr. Rajiv would know it better. That is other thing. On the private side of it, I think what is going to come in is, because financing has been our pain point, where to raise that, it better than anyone else coming from a private sector background. You need to give returns to the investor. If I
Yeah.
put so much money in a greenfield project, people are not willing to, put that.
They don't have the patience. They don't have the patience
Yeah.
for that.
So I think that REIT kind of a thing, that real estate investment trust, kind of a thing, which is already now come in. I think that will be the model which the private sector will want, where someone else comes in, puts in the infrastructure, is not too greedy to take, their requirement is 4-5% on the capex that they do, that will allow the private sector probably, to come in with a bigger force. Otherwise, private sector, unless they get maybe a softer interest regime, in COVID times, the government came up and said 6.5%,
Yeah.
loan, that would be, so something like that probably will
Okay.
catapult the private sector.
Okay.